All right, without further ado, patient-centered care, health communication in the era of publicly available medical information and misinformation with Ilona Fridman, PhD. Dr. Fridman, welcome. We're so glad to have you here today.
Thank you.
Absolutely. And we've got a lengthy bio. I'm not going to read all of that, but I do want to point out the top five, well, what we've compiled as five of the most important pieces of information from your bio. You completed your PhD at Columbia University and completed your postdoctoral training at the Duke Margolis Center for Health Policy and a T32 fellowship in the University of North Carolina's Cancer Care Quality Training in Cancer Outcomes program. Dr. Fridman is an assistant professor at Georgetown University Lombardi Comprehensive Cancer Center and an assistant professor at Hackensack School of Medicine. Received the UNC NC Tracks Pilot Research Award in 2022 and the Career Development Award, K22, from the National Cancer Institute. And finally, research has been published in top journals like JAMA, Journal of Medical Internet Research, Journal of Oncology Practice OP. Does that sound about right, Dr. Fridman?
Yes.
Good, good. Well, that's impressive. And as usual, we ask our presenters to share something outside of the professional realm. What's something else that we should know about you?
Well, you told me before fun facts. So I was thinking
Yeah.
about fun fact. And recently, my 10-year-old dragged me into computer gaming, and I'm really enjoying playing with him various computer games.
Oh, that is great. That is great. Any favorite games?
Yes, it actually takes two. I highly recommend everybody who have kids around 10 years old. It's so fun. It actually builds collaboration with the kid and teaches you to be in a team, be persistent, reach results. Actually, advertising. I think they should pay to me for this advertisement.
Uh-oh, we may have to add another COI. No, no, we're good. All right,
No,
Dr.
that's pretty
Fried,
fun.
thank you for that recommendation. And I mentioned poll everywhere. So the question is, have you seen any misinformation online regarding cancer? And yes, no, maybe. Let's see. I'm going to go back. I apologize. That's not populating correctly. Andrew, is that something we can fix real quick so that we can see those responses? Bear with us for just a minute. Once in a while, poll everywhere needs a little nudge before we can see those responses. Hopefully, you're seeing the question coming up now, and then there we go. All right, we'll wait about 15 more seconds, but we are just based on the answers that have already come in. It sounds like this presentation is going to have a lot of relevance. We're seeing 100% of the participants who've responded saying they have seen misinformation online regarding cancer. So with that, Dr. Fridman, I'm going to turn this over to you. Health communication in the era of publicly available medical information and misinformation. Oh, and Dr. Fridman, you may be muted there. Sorry.
Thank you. Thank you so much, Tim, for introduction. And I'm so excited to be back with UNC folks. You will see a lot of research that we did and actually did together with health providers, with patients within UNC. So I'm going to talk about cancer misinformation and give you examples from cancer care, because that's where I'm working mostly. But a lot of examples, and especially strategies that we recommend physicians to use, will be relevant to many different conversations. Okay. First, I wanted to start with the story. This is about a patient I interviewed several years ago, and that's how my interest in misinformation started. The patient was diagnosed with stage 4 cancer. And she was running out of options. She was interviewed. I was a researcher there talking to her about decision making. And she told me that she found somewhere online that raw vegetable dieting can help her to stay cancer free and prevent cancer progression. And despite the fact that her providers told her that if she eats proteins, she can restore her body and tolerate chemotherapy better, she was adamant that she needs to go with raw vegetable dieting. And if you think about it, it's really hard for patients because she cannot tolerate it well after chemotherapy. She does have fatigue. She cannot cook for herself. And despite disagreement with providers, she believed that it can help her, and she blamed herself for cancer progression, feeling ineffective and really upset with herself, which is really disheartening. And this story made me think how people perceive information and what they value as an important and worth acting upon. Why sometimes they evaluate advice from somebody else more important as an advice from comparing to advice of their physician. And before I go further and dive deeper in the research, I wanted to give you some fact about me, which I think very relevant to this conversation. I was born in Soviet Union, and I'm from Russia. What I experienced as a teenager, the Soviet Union collapsed around 90s, and everything that was true for us at that moment of time became not true. And it's like a world went upside down. We came from one truth to another truth with very, very, very strong emotions. So that was during my teenage years. And then now I also wanted to tell you that I'm not only from Russia, but I'm partially from Ukraine. My mom from Ukraine. I spent half of my childhood in Ukraine. And now I'm not only studying misinformation, but I'm living misinformation because I can read news from the US, I can read news from Ukraine, from Russia, and all our personal conversation actually filled with misinformation, trying to figure it out what's true, what's not true. Let's go back to cancer and health misinformation. And I wanted to turn the microphone to you and see what's the temperature in the room. And I think you already answered that you encounter misinformation in your practice. And think about the practice. Whenever you talk to patients or clients or students, have you encountered those conversations misinformation? And have you ever felt ineffective in those conversations? Now it's time to use our poll. Okay. Super. Let's see next one. Did you feel ineffective in communications? That's great. Thank you so much. And I think a lot of people felt ineffective. I feel ineffective very frequently, as I just told in my personal communications. And that's probably partially I'm trying to understand what are the strategies and how we can be more effective to bring people together and make people talk honestly about options available to us. Okay, why should we study misinformation? First, I wanted to tell that people receive information today mostly from various sources and from online because it's available for them 24/7. 72% of adults go online first for health information, and it's across different contexts. We ran a study in UNC, and we asked patients with cancer and their caregivers report their willingness to use social media for medical decision making. We found that 65% of people said yes, they will make some decisions using social media. And if we split their answers by different social determinants of health, as you see on the screen, you see that black participants were more willing to use social media than white participants. And that's consistent across different studies. I ran a study during COVID, and I found that non-white population trusted Twitter and Facebook on COVID information more than mainstream population. Some other information within those studies that people with lower education, people usually living in rural areas, lower income, they trust information outside of clinical settings more than mainstream population. I told that people go online for information and to different sources. What is the quality of information online? The studies show that about 40% of health-related posts in social media across different contexts contain unreliable claims or misinformation. If you look at specifically at cancer misinformation, it's about 30%. Misinformation is more prevalent in posts about prevalent cancers. For example, 70% of posts about prostate cancer and 51% of posts about breast cancer contain some misinformation. And 77% of misinformation that people can find contain some harmful recommendations. And I'll speak more about it as we go. What are the consequences of misinformation? People exposed to it, but do they act? Do they follow misinformation? People who made misinformed decisions about cancer therapies decreased adherence to standard therapy, increased risks of premature death 2.5 times, experienced financial toxicity. About 6.7 million were raised online for therapy that were proven to be ineffective for cancer. And this specific study also shows the similar results for other contexts. And people experience psychological distress, as I just showed in an example at the very beginning. Okay, another long-term consequences of misinformation is that we slowly losing population and losing people's trust to science overall. This is an interesting study that was done before January 2025. The percentage of adults who regarded the cancer for disease control and prevention as excellent or good fell from 64% to 40% during COVID and never recovered. And we don't have data yet since January 2025. Another one, it's important to know that patients and population generally trust their doctors a lot. However, there are some concerning trends, like in this study, which show that trust in personal doctors decreased from 93% to 85%. Still high, but trends decreasing. And another interesting study showed that 40% of people in the US believe that cancer can be treated by natural therapy only. With this introduction, I wanted to bring your attention to our objectives today. I hope I convinced you by now that misinformation is important and influence decisions of patients across different contexts. And I thought that it would be important to discuss definition of misinformation, examine pathways that lead patients to interact with misinformation, and discuss how we can utilize evidence-based strategies to address misinformation. Okay, let's start with the first. Define misinformation in research and practice. And again, I'm turning microphone to you, and I want you to enter one word. How would you describe misinformation? Just any word that comes to your mind. And this is going to be a word cloud. Define or describe just one word.
And bear with us for just a moment. We're going to see why that's not populating, but I think we'll have it fixed in a moment. Looks like we still have more coming in, maybe just 10 more seconds. All right, I think that's most of the responses.
Okay, beautiful. Thank you so much for your participation. I really appreciate your engagement, and it's really interesting to see your opinion. It happens that other people before us also thought about misinformation, and they came up with 52 terms. We're not going to cover them today, I promise. Can you hear me?
Yes, loud and clear.
Okay. Because I think I saw something in the comment. Okay. We're not going to cover 52 definitions of misinformation, but what's important, it's important to know how to operate in the world when we really don't know and cannot define and cannot agree what's misinformation. First, there is a general definition for health professionals. This is very, very general, and it's actually not helpful when you think about using it in practice or research, but that's how it sounds. Misinformation is information that contradicts the consensus of the scientific community regarding a phenomenon at a given time. Okay? And what we did with this definition, we wanted to get one step further. We wanted to know how we can define harmful misinformation for health professionals. I noticed the word dangerous, big and loud on our screen, and we were thinking about it too. So we ran structural review. That's how I know that there are 52 definitions of misinformation. And we were focusing on specific characteristics of misinformation, whether it's observable, generalizable, and simple. And that's the framework that we came up with. So there are three important questions we need to ask. Whether information is actionable, whether information is factual, and whether information is verifiable. Let me give you an example. For example, if a patient reads somewhere a false cancer diagnosis of a public figure, this information is not actionable. There is nothing can be done about it, or it cannot influence decision making in most cases. In this case, when we encounter it, we decide to discard it without discussion. Just go to the next step. So if information is actionable, then we need to see if there are any facts that we confirm or disprove it. If there are facts that disprove the information, for example, starve cancer by removing sugar from your diet, and that's not how it works, and there are studies showing that it doesn't help. In this case, we need to note this knowledge as potentially harmful. Another possible answer to this question about facticity is we don't know. And then we need to check whether information is verifiable. In certain cases, there is no evidence. We don't know if it's verifiable or not. Like in an example, high dose of vitamin C inhibits growth of cancer cells. The effect in humans is unknown. The studies show that it works as long as it's in a laboratory, that there is no tests in humans, and it can be dangerous in high doses of vitamin C. So in this case, we recommend patients consult experts about the effectiveness and safety of the discussed therapy. And we also can answer a question as information is factual. I just showed a study where patients were nearly 2.5 times as likely to die if they used an alternative therapy instead of standard therapy for the first months before they started standard therapy. This information might be considered to inform medical decisions. Now, I wanted to spend a couple of minutes and show how we use this definition in research. We wanted to identify cancer misinformation on Twitter. And we came up with the following definition. Unproven therapies or substances presented as cancer cure. So information that can inform decision-making because it's treatment, presented as treatment. It's non-factual. We looked only at lists of unproven and ineffective cancer therapies. And how we decided to deal with verifiability, we decided if we cannot verify information, we're not going to mark it as non-misinformation. That worked for our goals. Here is a brief example. For example, a person can find online acupuncture can help you to treat cancer pain. This is not misinformation. This is actually, there are studies showing that that works. On the other hand, the same acupuncture can be presented as cancer treatment, and in certain cases, wild cases, that cancer cure, which we don't have evidence. And actually, in this case, we have some evidence that doesn't really work. And that will be misinformation. So with this idea, we went online and we collected 45,000 posts about unproven therapies for cancer. We identified that in 30% of cases, they were presented as cancer treatment and cancer cure. Most of those instances were related to diet-based approaches. For example, don't consume sugar as cancer thrives on it. Alternative medicine systems. Example is create an alkaline environment that cancer cannot thrive in incorporate herbs, vitamins, and minerals to support your healing journey. You are going to heal. And plant synthetic-based supplements. Something like cure for cancer that works holistically, vitamin B17. Very good. Okay, we also did one more step further with this data. We wanted to know what are the characteristics of misinformation, linguistic characteristics that we can recommend patients to look for and identify misinformation before they start even investigating what's true, what's false. So linguistic characteristics refer exactly to how people write and what words they use. We found that predictors of non-misinformation were tentative language, maybe likely mentioning of location, hashtags, and website links and other URLs. Three of them can be united as a version of citation. There is some reference to something whenever people are sharing information. And predictors of misinformation included numbers and opposite of tentative language, absolute and language and certainty. That's how it looks like. So, for example, vitamin B17 has definitely prevented my cancer. So this is certainty. Or cancer is nearly 100% curable, but be aware of certain hospital treatments. Explore alternative options for better outcomes. So that's numbers and certainty together. And we recommend on social media, be careful with confident certain language and presence of numbers without clear citations. In this case, those posts can be just discarded without any further investigation. Okay. So takeaway message from this objective. Definition of misinformation should be specified for each project and context. While encountering misinformation, consider three things. Is it information actionable? Do we have factual evidence? And if we don't have any factual evidence, we need to acknowledge its unverifiability of some information and discuss specific risks that might be associated with it. Okay, that concludes my objective 1, and now we're going to objective 2. We're going to examine pathways that lead patients to interact with misinformation. I wanted to give you a right away example and tell that a lot of patients whom we interviewed and who participated in our studies across different contexts said that they actually search for information, and that's relevant whether people diagnosed with cancer or any other chronic diseases. For instance, one of our participants told us, when I was first diagnosed and leading up to it, I dropped everything I was doing and I spent hundreds of hours doing research, maybe even over 1,000 of hours. Online information can be beneficial. Research shows that patient search for information improves patient knowledge, patient self-care. In cancer context, people can find complementary therapy, and complementary medicine can help with pain reduction, depression and anxiety relief, fatigue and body stiffness mitigation. However, misinformation will be also hiding in advertisements coming about complementary and alternative therapy. For instance, recent studies show that about 93% of patients with cancer were exposed to at least one form of cancer treatment misinformation. And that's how it looks like. Recent study conducted evaluation of advertisements on Facebook, Instagram, and Messenger. They found 310 paid advertisements that are pushed to patients. Patients don't need to search for it. It's just whenever they're opening their browser, and if they ever search for cancer, like for example, how to drive to cancer center, these advertisements can be pushed to them, to their screens. And that's how it looks like. For example, Immunity Therapy Center, which were proven to be ineffective, says that patients with stage 4 cancer and those who have been told they do not have any other treatment options find success with our alternative therapy programs. A person with incurable cancer gives the testimony for another clinic and saying that she's now living cancer-free. This is really disheartening. Those advertisement targeting vulnerable population who losing hope, and they want to believe no side effects, easy treatment, easy going, and gives them 100% results, which none of them is true. Now, I wanted to return microphone to you and ask you, how many patients with cancer do you think use complementary and alternative medicine? Think about it broadly, not necessarily which is harmful, good and bad, both of them. What's the percentage? Let's try the poll. You're actually very close to scientific results. Here's what science shows. Okay, I'm going to the next one. Yes, you're really close. The literature review of 25 years shows that it's about 55%, and it's stable across 25 years. Obviously with variations, depending on which population we look and depending how complementary medicine is defined within the study. This publication is coming. Another interesting fact here is that about half of those people who use it disclose it to their providers. So those people on frequently see providers, those people only those who have cancer, and they own treatment most of the time. And that's why they have opportunity to disclose. They're using treatment, active treatment, and they risk drug-to-drug interaction, but they don't disclose to their providers. How it looks from the perspective of patient. This is one of our interviews. She told us a story about hormone therapy. She said, they prescribe pill for me, but I don't take it. But whenever you tell them that, they want you to take it. And to make a long story short, I just don't tell them. I'm constantly taking my herbs, my soursop leaves, my soursop juice. Some of those contain cancer medicine in there. So I said, why not to take it straight from out there? When I take the herbs, there is no side effect on them. How patients finish up with those decisions? This is my research question. How and when patients decide to follow advice from non-clinical information sources instead of providers' recommendations? We did interviews. We interviewed patients who diagnosed with breast and prostate cancer, who are interested in complementary medicine, and we have responses from 19 patients. Then we did formal analyses of qualitative interviews, and we developed this framework, which in the next 10 to 15 minutes, I'm going to unfold for you. And this framework answers the question, what is the pathway? How patients finish up with the decisions that might increase risks of outcomes they don't really want. First, we'll start with motivation for information seeking. People have two general motivations. One of them, sometimes patients might be overwhelmed with information they receive from clinician, and they just want some clarification. They need information that's relevant to their decisions. One of the patients told us, when I first met with my healthcare team, it was like drinking water from a fire hose with all the information they were giving to me. And another reason is emotional. Patients want to know what's happening in the future. Sometimes it helps to solve some portion of uncertainty and helps them to deal with an anxiety. Here is what patient told us. I feel some of doctors were even getting maybe agitated or angry that I ask a lot of questions. Don't you understand that the person going through the horrific experience and to help lower an anxiety, you are trying to get as much information as possible. Just to know that information a little bit ahead of time. It helps you to calm down. It decreases an anxiety to a great amount. And that was missing a lot. I wish doctors would be just more humanely compassionate. I told you why patients are going for information. It's online and they can go to friends, to family, to some other patients. A lot of patients who talk to us and beyond in other conversation, in other studies, we see that people search for information. So information seeking experience, how does it look like? Here is confirmation to my previous words. Patient said, I can spend 5 or 6 hours daily online, seriously. And many of them acknowledge that they encounter unreliable and conflicting information. Patient told us, I'm not trained in the subject matter to be able to read scientific articles. The main challenge is to distinguish pseudoscience from actual science and decide whom you trust. The first thing that patients trying to do when they encounter conflicting information, they want to consult with an expert, and they frequently turn to healthcare providers. Patient told us, anything you try or want to try to, you need to check with the doctor, with your leading oncologist, to make sure it's not going to interfere with a particular treatment. And whenever patients are going to providers, they can encounter supportive communications or unsupportive communications. I'm going to start with supportive communications, and that was identified through the eyes of patients. Here is important sub-theme is clinical time and provider responsiveness. Patient told us, I usually walked in with a whole written list of questions, but they were very supportive. Nobody lost patience. The providers kind of liked the idea of answering those questions. Another one is engaging with information that patient brought to them. For example, a patient told us, I wanted to switch to that mushroom coffee. And then they said that doesn't work well with the chemo and all that stuff. For the most part, the doctors were on board as long as I was feeling okay. And the last one here is integration of patient-identified approaches or complementary therapy into cancer care. In this case, I invite you to think broadly about it. It's not necessarily complementary or alternative therapy needs to be integrated. Many patients in our interviews said, oh, I found something in a different hospital and I came with this idea to my provider, as it happened with this patient in this example. The surgeon I did choose, I told her what I wanted to do, and she questioned me and pushed back, and we discussed it. She even called me at home about it. She ultimately supported my decisions and told me at the end she would probably go the same route. That was a discussion about whether to do lumpectomy, that was physician wanted to do for her, or mastectomy, that was patient wanted to do for herself. The similar examples we saw with complementary medicine when patients coming saying, oh, I want to do this, and providers find a way to integrate it. For example, for herbs, providers can say, please don't use it when you're on chemotherapy, but after that, it's probably fine. Okay, if we can discuss supportive communications, now we're going in the realm of unsupportive communications. And the first sub-theme mirrors the first sub-theme in supportive communications and relevant to time. Patients have experience like those. I still feel that there is not enough communications between doctor and patient when you come. You had a lot of questions and you have exactly 5 to 10 minutes. There is no way I would actually discuss with her any of the therapy. It's literally only urgent-based care. Patients' concerns are not taken seriously. I was very adverse to chemotherapy. Doctor was very much in favor of the cookbook, which would be lumpectomy, chemo, and radiation. And we hadn't really come to a decision. But then she sent me to a scheduling department. And next thing I know, they are scheduling me for lumpectomy. That was very upsetting to me because I hadn't agreed to that. And in this specific case, the patient left that provider and went to another provider. And the other one is failing to recognize patient preferences. This sub-theme is relevant to question, why didn't they tell me before? Patients go through the treatment, they identify certain things, certain side effects, or something that they didn't expect, and they're saying, why provider didn't tell me? Like in this case, when I first started my second course of chemo, they didn't tell me that it would cause menopause. I'm like, if you told me that it caused menopause, I would have had a huge party and celebrated it and tried to live it up as best as I could. But I didn't know because they didn't want to tell us. Unsupportive communication might increase risk of misinformed decisions. And that's how it looks like. Misinformed decisions have 3 stages. One of them, first, trust goes down. In many, many cases, patients stop asking. Like in the earlier example I showed to you, when patients said, I'm not taking the medicine, but I just don't tell them. Or they're taking some herbal therapies and they don't tell them. In this example that I wanted to show you, it's pretty extreme. That went all the way to very low trust. And it's rare. I need to acknowledge it's really rare. My advice is don't believe the doctor only 50% or less, because this is business. The salesperson is the doctor. He just has some knowledge about certain things he has learned, and that's why he tries to sell them to you. That's all. The next step is relying on the opinion of non-experts. If patients cannot verify information they find outside with their providers, they go to other sources. like this gentleman. There was a prostate cancer forum on the Facebook, which I found very helpful because it was all gentlemen who had been down the road before me, all these different success rates and different outcomes, and chose different options of treatment. This information can be reliable from the forum or unreliable. We never know what other patients have and how it's applicable to specific patient. And the last case, also very rare. Many patients adhere to medicine, but in some cases, if patients they reduce trust, they consult with non-experts, with complementary medicine and alternative therapy experts, they might stop taking standard therapy. I had read horror stories about tamoxifen all over the internet, and I'm not taking tamoxifen. I started the holistic treatment for a month. I found a woman in town, and she got me started on a lot of the stuff. I do still take it, but again, I was going as my solo plan. So this patient, she decided to go with alternative therapy before she started standard therapy. And as I showed to you overall statistics, this decision potentially might be misinformed and lead her to the outcomes that she doesn't really want. Okay, this is the framework that I just presented. And this is qualitative results. It's not quantitatively tested, and it needs to be quantitatively tested before we can confidently say that it works this way. But this is what we're suggesting, how it works. For instance, if a person comes with strong trust and then goes through a very good conversation with provider and feels like maybe something unclear, they Google information, find information that is unrealistic or not supported by evidence, trying to confirm it with provider, but do not have chance, and its risk of misinformed decision making will be increasing. Now let's imagine a patient who said, I trust providers only 50% or less. In this case, patient comes with very low trust already. They Google information on their own, but they go through supportive communications multiple times, not just one supportive communication, but with team, nurses, or supporting staff in the clinic works together, and provider comes every time supporting patient. In this situation, we can decrease risk of misinformed decision. Okay, takeaway message from this objective. Using clinical time mindfully, and I'm happy to discuss it during Q&A. We just wrote a narrative review. I know it's a huge pain for both patients and providers. And we gave a perspective of both patients and providers in our narrative review and find some suggestions how we can improve it without drastically changing the whole healthcare system. Another one is acknowledging and taking patient information seriously. Integrating patient-identified therapies could help with maintaining patient trust. This is words of provider whom we interviewed on the different instances, and she just really nicely put a recommendation together in a sentence. She said, I found that if you just say no to everything, patients shut down. But if you are willing to compromise on some things, then patients are willing to work with me. They understand. That concludes our objective too. Now, what do? We know that patients search information outside of clinical settings. We know why they're doing so. And we know now barriers that they experience, both actually experience, not only patients, but providers also experience barriers with all this information search and with best intention to validate patients' information. There is frequently not enough time or not enough space to do so. So what are the ways? How we can optimize it? I wanted to start this portion with an example. It's based on interviews. Now, while it can happen in different contexts, let's think about a patient who was diagnosed with cancer. And now she comes to a provider and she wants to validate information that she found online. She says, I went to this herbal place and I was talking to the guy and he said, okay, I'm going to give the supplements. Is it safe? How much to use? When to use it? Does it interact with chemotherapy? Is it going to help with anything else other than those things, the nausea and fatigue? So what are the provider's reactions? I actually have data on that, and I'll show to you in a minute. How providers react when patients ask them about information they found outside of clinical settings. before I show you data, I wanted to ask you, if a patient brings information they found online to you in your everyday clinic routine, there are two options, and please be honest. We all know what's the right thing to do, but we need to understand where is the gap right now. And I'm, as a researcher, will benefit from your responses to see how far we are or how close we are to what we need to do. Please answer those questions and choose the options consistent with what realistic, not with what need to be done. Okay, two options. Redirect the conversation to highlight strong scientific evidence supporting your recommendation. Examine the evidence behind the proposal and explain clearly why it is ineffective. Okay, here are the options in our poll. You know, you just supported my study. That's amazing. We're going really close with our investigation. This is approximately what we see in the results. Okay, let's see. So we asked patients. We went on a forum. It's a health union. It works like patient like me. If you know this, a system, it's when patients sign in and there is a moderated forums when they can ask questions among of questions the patients who went through the situation before them. We recruited 173 people who diagnosed with cancer. And we asked them this question: if you brought the information to your provider, how did provider reacted? Similarly, as you just responded, many providers reacted in a positive way, in a reinforcing way. However, we also found that about 31 to 37% of patients with cancer reported provider strategies that were negatively associated with trust in provider's opinion, future disclosure, and decision self-efficacy. We had open-ended question, and we asked to unpack what was the reaction, what was exactly was told to them. And we found that one of the examples would be often I'm ignoring. I often feel like I'm being brushed off when I mention things I have learned. Discouraging. My husband looked into medical marijuana. We asked about an alternative. We were discouraged to look further. And judging. I did research on the internet. My surgeon almost made it seem foolish that I would even look. So now we know what's ineffective strategies. And it's missed opportunity to build trust. Let's consider what would be effective strategies. And in this study, we pushed it even further. It's not with just validating information, but we must disagree with whatever patient bringing to us. So if you need to disagree with patients, which approach would likely lead to a patient trusting the physician opinion? Okay, that's how we run the experiment. So this is patients who diagnosed with cancer, and they were randomized in 3 different groups. They read the instructions. I imagine that you found a new treatment for your cancer online. You ask a healthcare provider about the treatment. Here is what happens. First, the doctor quietly looks at you while you are talking and then says that you should not believe everything on the internet. The doctor turns to the conversation to a different topic, which is related to the treatment supported by his/her clinic. So that condition we call dismissal. So the provider didn't engage with the information. Second one is the doctor states that his treatment is not really going to do anything. The doctor explains that the information you have found about the treatment is likely incorrect. It's cancer misinformation. The doctor provides a detailed explanation of why the treatment is not going to work for you. So this is the most recommended approach, right? Whenever you hear word misinformation, people usually tell, you just need to educate patients. And that's a condition that we try to replicate here. And the other one, we copy paste our scientific explanation and we added 2 sentences. One sentence at the beginning, it says, the doctor listens, acknowledges, and confirms his or her understanding of the information. The doctor says that regardless of what you decide, she or he will still take care of you and will always be available to answer your questions about those kind of things. So my second and third condition, they identical except of the 2 sentences. Okay, now we're going to look at the results. The first question we asked, will you share again similar information to the same provider? And my columns represent the conditions, exactly organized as on the screen before. And you see on axis Y, those are percentage of people who said likely, highly likely, like top two choices on a scale. And in this question, you see that people saying that they will share information in the future in dismissal condition, about 35% of them will do it again. 44% of people will do it if they receive scientific explanation, and it's more than a dismissal. But the only significant difference we saw if we used those relationship building sentences in our explanation and relationship condition. So there is a significant difference between this condition and dismissal. The next questions, whether patients were satisfied with interaction, felt opinion was respected. The same as before, we see that slightly better, for example, patients feel about whether their opinion was respected. If they receive just explanation, but no significant difference with dismissal, only if the relationship component was present there, we observe significant difference. And my favorite question, will they trust physician's opinion? So we gave them scientific explanation. Will they believe us? And we found that only if provider invested in relationship building, specifically with those sentences, we found that patients will trust physician opinion more than comparing to dismissal condition. Okay. In conclusion from this study, approaches that will increase patient trusting in physician opinion, taking patient information seriously, acknowledging it, and reassuring patients that they will be supported when they make their decisions, regardless of their choices. I wanted to briefly, before we end, show to you other studies. This is the study which was done in parallel with me by different researchers, and I didn't know about the study until recently. So they finding that to address misinformation, providers need to work and understand misinformation, be open to this knowledge, educate self, and take information seriously, similar to what we're doing. And then a correct misinformation through education. This is my second condition. That's exactly a recommendation from other researchers. And new one, which is not in our research, but they're suggesting also direct patients to resources that providers think are reliable. And our favorite, preserve the clinician-patient relationship. And I just show through which words and which framework of conversation you can achieve this. Overall, takeaway message for today's conversation is that publicly available health information impacts knowledge and adherence to health recommendations. A substantial proportion of patients search internet but hope to validate their decisions and medical professionals need to focus on building relationships via engaging with information patients find, providing education, and identifying compromises and individualized solutions when it's possible. And now, one more time, I wanted to turn it to you. This is a summary of our conversation by 3 objectives. Feel free to post your questions relevant to any of those objectives, and I would be happy to stick around and answer any questions.
Dr. Fridman, thank you so much. This has been fascinating. And I'm going to leave that up for just a few more seconds, and then we'll go over to our Q&A. And I'm just previewing. Okay, I'll go ahead and share that first question. Again, for our audience, if you have questions, you can use Poll Everywhere to submit those questions. We'll get to as many of those as we have time for. This first question is a lengthy question. I'm glad to be part of this webinar. I am Marine Riaz, a first-year PhD scholar from Kashmir. I plan to pursue my research in psycho-oncology, and I am particularly interested in exploring how cyberchondriasis can contribute to the psychological burden in patients. I would be deeply grateful for your guidance in finalizing my research topic. There's more of this than we can get to here. This individual is really reaching out. If possible, I'd be honored to have you co-guide. So we'll go ahead and forward that full question. But do you have any initial thoughts on the question?
So the question is how this all use of cyber information can contribute to
Hmm.
psychological burden, right?
Hmm.
Okay. There are studies showing information overload and saying that at a certain point, patient can shut down and stop exploring, which is bad. In our case, it's bad. We want people to be rely on their self-support a lot. They receive treatment in medical centers, but then they have to go and live with this treatment and deal with side effects. Therefore, we want them to be educated. And obviously, people overwhelmed just by amount of information. And as I mentioned before, they get confused because they see promises as very aligned with their wishes, that they want treatment without side effects, that they want treatment with 100% results, 100% cure. And then they making those decisions and then it doesn't work, right? They go to alternative therapy and it doesn't work. And then they blame themselves. They're thinking they're doing something wrong. As a patient in the first example, and we almost need to have some supportive services for people to shake through information, just to make
Gotcha.
sense of this information.
All right. Thank you so much. And I will forward Dr. Riaz's full question and contact information to you so that you have that information. Next question. What are your thoughts on frustration professionalism when feeling ineffective in addressing misinformation? Great
Well, I
question.
think at some point of time we have to step one step like back. Sometimes we're trying again, we're doing our best, we're using all the strategies, but people adamant, they believe in something else. We need to step away, think about it, and allow patients come back and be always welcoming. Whenever people coming, just we need to be there for them. That's important. Uh, im- One important point here, we cannot shut them down. We can say like, if you don't agree, just go and be somewhere else. Sometimes they don't have choices. They cannot go anywhere due to their financial issues or access or anything. And in some cases, it's indeed leads them to misinformed decisions. So be present. Sometimes uh, take a pause and come back again.
Great. Thank you so much. And I know we're running out of time, but we've got just a couple of minutes. So we did have a comment, clear, concise, informative. I couldn't turn away. It will be so helpful in my practice. So thank you for that comment.
Mm.
Um, as I'm thinking about this, I'm wondering, about the role of clinical trials and how this plays into patient speculation about other treatments, because of course we hear so many positive things about clinical trials and participating in clinical trials. And I think patients have an awareness that there may be something that's right on the cusp that's being explored, that's being researched, and they don't want to be too late for the findings of that next clinical trial. How can clinical trials play into this, either in terms of maybe in some cases leading to some extra anxiety, or in other cases where a patient may go ahead and be encouraged to enroll in a clinical trial as a way to explore another option, even without knowing definitively what the research will lead to?
This is such a good question. It's almost opens a new webinar. We need to stay another hour just discussing this. Because part of it, there are two things to that. One of them
Mhm.
is that we need to learn how to explain clinical trials in the way that patients understand, right? It's so
Mhm.
hard, and it's so hard to distinguish because misinformation is very clear. And now we're coming this very complex information, maybe this, maybe that, and it's hard to delineate what's actually happening. There are new approaches. I am right now at conference, and there are new approaches using AI, how we can explain clinical trials with videos, with topics. But second to that, we need to be very clear what's the risks and benefits of it.
Mhm.
The best decision when patients can tell you, I understand my risks. Like for example, we have in one of the interviews, and provider and patients were discussing, they discussed acupuncture for certain side effects, which is acupuncture not meant for that. I'm bringing this example, but it's relevant to clinical trials. And patient said, I understand it might not work. I'm fine with this. My risks, I'm spending money, I'm spending time, and I'm not really having any additional side effects. I'm willing to
Hmm.
go. And this is
Hmm.
a beautifully informed decision. That's
Yeah.
that type of the decisions we need to implement with clinical trials when patient tells you, I know it might not work, but nothing working for me right now. And
Hmm.
I see the side effects, I can live with that. And then that's informed decision. And with guidance of expert, they probably will not be that overwhelmed and can safely choose something that fits them.
Right. Thank you so much. I know we are just about out of time, and I know that you need to leave right at the hour. So here is contact information, and this will be in the recording as well. Thank you so much. Here are references. Again, I'm not going to linger on that, but that's in the recording. We want to thank the state of North Carolina for the funding of this program through the University Cancer Research Fund. We want to thank the UNC Lineberger Comprehensive Cancer Center, our team, Benny Obore, John Powell, Oliver Marth, Andrew Dodge, and Patrick Muscarella, and Kimberly Riddick.